Alrighty guys, welcome back to the channel and to today's presentation, and we're going to discuss two disorders today, that of diabetes insipidus and syndrome of inappropriate antidiuretic hormone. Now these disorders are total opposites, so throughout this presentation we're going to want to know that one is hypervolemia and the other represents hypovolemia, okay? So in diabetes insipidus, this is where the hypovolemia will be manifested, which is fluid volume deficit, and in SIADH, this is hypervolemia. There's going to be too much fluid within the body. So we're going to start with diabetes insipidus, and no, this disorder has nothing to do with diabetes in general, but when discussing it, just think hypovolemia as I just previously mentioned, and we're going to think hypovolemia because there is a bunch of fluid output, okay? Now, the pathophysiology behind diabetes insipidus is that there is a lack of ADH, which is antidiuretic hormone, and this is the hormone that retains water within the body. So if there is no ADH or antidiuretic hormone, like in the case of diabetes insipidus, well, there will be no water reabsorption, meaning the water will just constantly be excreted through the body as urine, okay? So this is going to cause low fluid volume due to the excessive excretion of the fluid, and that's going to cause the hypovolemia. Now, causes of this disorder pertain to things such as kidney trauma, damage to the hypothalamus by means of trauma or tumors, and even intracranial pressure, guys. Now, because the hypothalamus is what produces ADH, if it is damaged, there will be none produced, okay? So there will be a lack of ADH. It is the posterior pituitary gland that secretes the ADH. And when our blood pressure is low, ADH will be secreted to retain water, okay? So ADH is secreted to retain water, and when water is retained, our blood pressure goes up. Now, the clinical manifestations will reflect hypovolemia. So if you guys have watched my fluid volume video, this is going to be pretty straightforward. So due to the excessive water loss through urination, polyuria is definitely going to be seen, along with polydipsia. And polydipsia is the excessive thirst. Polyuria is the excessive urine output. Now, nocturia, this is going to also be manifested, and this is frequent urination at night, so nocturic episode. And now with hypovolemia, guys, this is going to cause dry mucous membranes due to the lack of hydration to our mucous membranes. There's also going to be a decreased blood pressure due to the decreased fluid volume, and there's going to be tachycardia, guys, which would point to the potential shock. Therefore, the heart will increase in beats to compensate for the missing fluid within the vascular system. Now remember, when there is fluid volume deficit, this is signs of hyponatremia. And in this case, this is going to be represented by euvolemic hypernatremia, which is a type of hypernatremia, okay? And in euvolemic hypernatremia, excessive fluid is being excreted, but not the sodium. So you could just think of a fluid shift that's going on there. Sodium's up and fluid is just getting out of the body in ridiculous amounts, okay? Now, also being that the fluid is low, our hematocrit, which is the concentration of total red blood cells within whole blood, is going to be high, okay? There's a lack of fluid. These are going to be elevated. Now, in previous videos when discussing hypovolemia, I've said that the labs are usually up when there's a low fluid volume, but that was due to renal damage mainly, okay? If the renal system is not excreting anything, everything is going to just build up, which is going to cause an increase in lab values. Here, there is no kidney damage. Just think that everything is literally just being excreted out the body in excessive amounts, okay? So the lab values are going to be low as well because everything is just getting out of the body. So with that being the case, there's going to be a decreased specific gravity, for example, and specific gravity, guys, is the concentration of particles. And now particles are going to be low because the particles are getting out of the body, as I just mentioned. Now, what also follows these particles out of the body is the fluid that we are also losing, which is manifested in diabetes insipidus. Now, moving along to diagnostic evaluations of diabetes insipidus, this includes serum osmolality, urine osmolality, along with our electrolytes. So we're going to want to look at all of these to see what's really going on in the patient. Now, the key indicators of diabetes insipidus point to a low urine specific gravity, which is less than 1.005, and urine osmolality less than 200 millimeters osmoles per kg, okay? So the management for diabetes insipidus is going to start with fluid replacement using hypotonic solutions, okay? Remember, hypotonic solutions draws fluid out of the vascular system and the fluid goes into the intracellular spaces, furthermore swelling the cells and restoring that volume to them, okay? So this is mainly for the dehydration. We're going to want to rehydrate cells, which is lacking any hydration due to the fact fluid is being excreted out of the body. Now, also during IV administration, monitoring for hyperglycemia and fluid volume overload is going to be very important as well, and especially correcting that hyponatremia that is being manifested within the diabetes insipidus. Now, desmopressin is a synthetic analog of ADH, meaning it promotes antidiuretic properties, okay? So this is the drug of choice in patients with diabetes insipidus. Lastly, vasopressin, also called pitressin, and this is less expensive than the desmopressin. All right. Now, vasopressin works like antidiuretic hormone in that it increases water reabsorption in the kidneys. Okay. And when we increase water reabsorption in the kidneys, we furthermore increase fluid volume, furthermore increasing our blood pressure. Okay. Now, both desmopressin and vasopressin, they reduce polydipsia, which is that excessive thirst, as well as decreases urinary output. Now, when all is said and done, these medications definitely just serve to increase our fluid volume, okay? So it's compensating for the fluid we do not have. Now, the nursing interventions focused on are as follows. Vital signs will be important as always, and in this case, due to the excessive water loss, there's going to be a decreased blood pressure, guys. We're going to want to monitor that blood pressure, make sure the patient doesn't get too hypotensive. And we're going to look at the pulse rate as well, because when we are hypovolemic, it's more than likely that we're going to have tachycardia to compensate for the fluid loss. Moreover, intake and output is going to be monitored. We're going to want to restrict foods that promote natural diuresis or water excretion. Remember, we do not want to lose any more fluids than we have already lost. We're going to want to do daily weights, and due to the excessive water output, guys, this will lead to a decreased weight in the client. Now, we're also going to want to maintain IV access in these patients, so keeping the vein open, KVO, is important in case we want to provide IV hydration. And as we just mentioned, that hypotonic solution is going to be implemented here, and our hypotonics are 0.25 normal saline, 0.45% normal saline, or dextrose within water. Okay, those are examples. Also, guys, maintaining an IV access is going to be vital because placement of an IV catheter in a hypotensive patient is very difficult. There is no palpable veins. Veins are very flaccid and it's hard to find the vein, so keeping that vein open for IV access is going to be very, very important. Now, providing adequate oral fluids. If the patient is alert and awake and has an intact gag reflex, the patient is allowed to drink fluids, okay? If they have an intact gag reflex. Other than that, if they don't, we cannot provide the fluids to them because it's going to cause possible aspiration, the patient can choke, and it could cause other complications that we just do not want. Okay. Moreover, administering meds as ordered, such as desmopressin, as we mentioned, and vasopressin, is going to be important. And remember, these are going to cause water reabsorption in the kidneys, and that's going to help bring up our blood pressure and vascular volume. Now, we're going to provide adequate fluids and monitor for fluid overload due to the IV hydration, okay? So yes, we are giving hypotonic solutions to increase permeability to cells, increase vascular volume, but we're going to want to definitely monitor the patients on these solutions, because if there's too much hydration in these patients, they can swell up, they can become edematous, okay? We do not want the edema in the extremities or in the body. And lastly, guys, we're going to want to evaluate the urine output, and we want fluid output in the range of 30 to 80 mLs per hour, okay? We want them to urinate 30 to 80 mLs per hour. Anything under 30 mLs per hour is going to be termed oliguria, and if it's really, really bad, it's going to be termed anuria, which is urine absence, okay? And we get to SIADH, syndrome of inappropriate antidiuretic hormone. And this is the opposite of diabetes insipidus. Instead of no ADH present, there's going to be too much ADH present, okay? And if there's too much ADH present, there will be too much fluid reabsorption, which is going to cause fluid overload, hypervolemia. That's why in the name, the I stands for inappropriate, because yes, it is being very, very inappropriate or excessive. So now, being that there's an increase in the ADH, again, there's going to be an increase in reabsorption of water within the kidney, and this is going to cause that same hypervolemia I just mentioned. Now, in diabetes insipidus, hypernatremia was a complication, and in SIADH, there's going to be hyponatremia due to the dilution of sodium, okay? There's so much water within the body, sodium is going to be diluted, furthermore causing it to have a low lab value. Now, causes of SIADH vary but include central nervous system disorders such as tumors that may grow in the brain or neck, as well as side effects of medications. So meds such as NSAIDs are psychotropic medications. These can cause or exacerbate SIADH. Moving along, the clinical manifestations are going to reflect hypervolemia. So that's things such as oliguria. Okay, oliguria is going to be a decreased urine output, and the fluid is not coming out because it is retained within the body. Okay, now anorexia, which is a decreased appetite, is going to be seen. GI manifestations such as nausea and vomiting. There's going to be an increase in our urine-specific gravity, and hyponatremia as well will be present due to the high fluid. It's diluting the sodium, okay, guys? And remember, hyponatremia, being that it is present, there's definitely going to be a seizure precautions implemented. Moreover, there's going to be neuro symptoms seen as well, and things such as confusion, irritability, and cerebral edema, all because of the increased fluid will be manifested. And definitely, if there's an excessive amount of fluid within the body, it can circulate to the brain, furthermore causing that cerebral edema, and the compression against the vein can cause that, decreased mental status. And that also correlates with ICP, which is intracranial pressure, okay? It's going to cause that confusion and irritability. Now, this disorder is managed in the ICU, the intensive care unit, and it is managed focused on hyponatremia. We're going to restrict fluids because fluid volume is already too high. Also, implementing daily weights and I's and O's is important for monetization. Diuretics, guys, are given to get rid of fluid, but remember, being that hyponatremia is in play, we're going to want to be careful when giving them because remember, when we lose fluids, we also lose electrolytes. So this can put the patients in an even more hyponatremic state, okay? So also hypokalemia can be exacerbated due to the increased electrolyte output. So we're going to want to check the electrolyte levels such as potassium before we give the next dose of diuretics, okay? As for IV solutions used, hypertonic IV solutions are chosen. And an example is 3% normal saline. Hypertonic fluids draw fluid out of cells. This shrinks them. Now the fluid goes into the interstitial spaces, and this can cause rebound fluid volume overload, which is going to be manifested as edema in the patients, okay? Now, moreover, a medication used, and this induces diuresis, okay? So it's going to help get fluid out of the body. So we're getting fluid out of the body. As for the interventions when given this medication, we're going to want to avoid giving foods that are high in calcium, like milk products or certain antacids, because calcium affects the absorption of dimeclocycline, which is pretty interesting, okay? So you're going to want to monitor what we put in our bodies that packs a load of calcium. And that brings us to the end of our video, guys. You can follow this video up with the videos I've listed on the screen. Enjoy the rest of your day, and I'll catch you guys next time.